seconds before we officially start. So come on camera. Make sure that you have placed your name and campus in the chat. Good evening. Almost ready to get started. Hopefully everyone is doing well. We will go ahead and call it official start time. Good evening and welcome to week 2. Make sure we're recording. Go ahead and place your name and campus in the chat. And you all know what's going on. Yes, I promise you, a storm just came up, but it just seems like it's going to be a lot of rain. So, nevertheless, we're going to push through. We're going to be ready for next week and Hesse and NCLEX and all that good stuff. Um, put my little timer on. So, give you a minute. Good evening for everyone that's just coming in. If you would go ahead and place your name and campus in the chat. Once you do that, go ahead and check your screen name. Ensure that your first and last name is correct. Make sure it matches the roster, however it appears on the roster. Okay, we don't want it to be thought that we were not here. So make sure you're correcting that. All right, let me get our course pulled up here. And welcome to week 2. Again, go ahead and place your name and campus in the chat. Check your screen name. If you need to know how to change your screen name, just let me know. I can walk you through the changing of your name. And hopefully we've got all that done. Let me turn a little timer off. All right, so welcome to week 2. As always, these sessions are recorded and they are viewed by the attendance administrators. Be sure to adhere to your guidelines. You must be on camera. You know, if you got a picture in your background, we need to see you. Otherwise, you're going to be marked absent. So we want to make sure you're there. In the event that you need to walk away from the camera, if you're not on break, put a message in the chat to myself. Don't send it out to everyone. Just drop a message, just what you're doing, restroom or whatever it is that you're having to do. That's the reason why you're stepping away from the camera. Okay. All right. As always, check your screen name, place your name and campus in the chat. So let's look at where we're at. Look where we're going here. I'm going to pull up our modules. So you know you can look at this. Let's look at the syllabus view. Let me pull that back up. See, can I make it? Okay, here we go. I'm going to share my screen here. And we're going to look at it 2 different ways. You know, we have to remember when we are making the care plans and plans for our patients, we are adjusting them to that unique patient. So this is one way of looking at it. This is your syllabus. So we're looking at week 1 and week 2 because we know week 3 will be tested on the information. So week 1 and week 2, we're looking at who does what, RN, LPN, and then of course we have to still know what the UAP does as well. We're looking at that nursing process, clinical judgment, and then we're looking at that legal and ethical. You know, what is that? What does that mean for us as the nurse? Okay. And then right here, week 1, we should be working on that quiz. Should be able to get in short path. If not, please let me know. You will need to submit a help desk ticket. Identify your leadership group project. We will tell you what that is today. And then this week right here, you have a lesson activity. That's in SurePath as well. Remember the lessons, you have the opportunity to work on those as many times as you can. But the way the quizzes are set up, you have to complete that in that one setting. Okay, let me toggle back to the course. Let's see. We go take that down. Let's look at the modules. All righty. So here we're looking at it again. You go to modules and you just scroll down. Week 1, again, we're looking at critical thinking. And I'm saying these terms over and over again. As we say these terms, clinical judgment, certain things should be coming up in your mind. And then we're going to look at the nursing process. Who does what? UAP, RN, LPN. And looking at the nursing law and the ethics. This is just another way of looking at what we just looked at. So whichever way you like, you want to print the syllabus out, download it, have it on hard copy, whatever, what have you, is good. All right. So do you have any questions before we get started? Our plan for tonight is to review everything. Week 1, week 2, just going back over everything. You will we'll assign you your groups. Remember, the group project is not due until week 10. But, it does take multiple meetings, and you will do that outside of class to get everything together so you can fine tune it as you like it. I know you said it's early on, but you go ahead and give you your groups and your topics. And it is a PowerPoint. And even though, for example, if there are 2 people in the group, 5 people in the group, what have you, you work on it together, whatever you all decide, you do a presentation, and you both, whoever's in the group, submit the exact same project, PowerPoint. So we'll get to that. We'll continue to talk about that a little bit more. So again, remember the dress code. Remember, you must be on camera. All those things, all those housekeeping things. So just make sure that you're safe and your surroundings as well. Hopefully you place your name and campus in the chat. If you're away from the camera, please put a message in the chat to myself as why you're not there. If we lose connectivity, you or I, just stay right there. We'll be back. So just stay there. All right, so let's go ahead and get started. So all of this is in, and we'll, in some of these slides, I just pull them all together, and I changed the pictures, but it's the information that you already have. I just like to change it up. I like some slides, to me, that we have them prepackaged. It's too much on one slide. So one slide, I'll create 3 or 4 slides. So nevertheless, you have the same information. It's just that I guess it's my learning style. I mix it up and make it conducive for me. And you can do the same thing with your PowerPoints. You have them there. In the event that you don't like the way they look, you can always go in and change what they look like. So, but I always like to start off from just getting you to think and we'll have these few slides every time before we, go into our content, getting ready for that exam. I always want you to just be thinking about what you should be thinking about. So you are responding as the nurse. So you're going to be given this scenario. And you can think of it as, your clinical day 2, clinical day 3. You go in, you get your assignment, you go in to that room. What's happened. So we want to read through the question carefully. You want to identify the subject or the concept. What is this question really about? Because remember, there are several questions that will have all these fillers in there. But then when it comes down to that main question that you should be answering, is only asking you about that one concept. So you do want to pick out keywords. Okay. So this is just repeating what I just said. If there's a scenario, I want to hear from you, with multiple things going on with the patient, how should the nurse proceed? Like what, and you can come off, let's see, you come off mute with this and respond. So step back and look at the bigger picture. So what's going to guide what you're going to pay attention to and all of that. Okay, so let me just hear from 3 of you all. If there's a scenario with multiple things, you walk in, you go into the room, the patient in room 201. And you have gathered your information, S&O, the UAP has reported things, the patient has reported things, you've got lab results, and I'm just creating a scenario just off top. How should we proceed with that info? How should we proceed in this instance? So there's no wrong answer. Just come off mute, 3 responses. Somebody tell me what you think.
Is something affecting their airway and their breathing?
Okay, you said something, determine if there is something affecting the airway or breathing. So, what are some words that, some descriptive terms that we use in nursing to describe airway, and also if there's something wrong with the breathing?
So when you need to proceed with what's the most critical at that moment. Um,
Okay, we said that there was something wrong with the airway. So, give me some descriptive terms or some words that would be used to determine that this person's airway is okay and this person's airway is in trouble.
Shortness of breath.
Obstruction,
Okay. So what would the person be sounding like?
Dysphagia.
Go ahead. What'd you say, Miss Lumpkin?
Oh, I said the dysphagia. That be
Dysphagia.
wrong?
What is
Like if you
dysphagia?
can't
Are you
swallow
saying
or having
dyspnea
difficulty
or are you
swallowing.
saying dysphagia? Tell me what that is. What's the definition of dysphagia?
Like if they have difficulty swallowing.
Oh, so you're trying to say if they're actually choking or something, they're eating and then they cannot talk to you, and you see it, they're having that what's that universal sign? People usually do this right here to their throat. Okay. So what about their sentences? If the person's having trouble breathing or moving air.
you need to see if restlessness, pallor is setting in. If they are turning blue, having cyanosis, you need to be listening to lung sounds, respirations. Determine if they need oxygen at that moment. You need to figure out what airway is being affected.
Okay, so how do we do that? According to the nursing process, how do we figure out that? We do what? Begins with the A.
vitals, or assess.
Assessment.
We assess, and all those things come up under there. So, shortness of breath, dyspnea. So, you all told me, someone said, look at airway, breathing, and circulation first. So, I need you to also, when you say that in your mind and you're translating that and looking at the scenario, tell me, what does that mean, airway, breathing, and circulation? You all were spot on. Person's going to have trouble completing sentences. They will be complaining of shortness of breath. If they were choking, they might you use a universal sign. We're listening to respirations. We're checking the oxygen saturation. And it can go both ways. If the person is not having any trouble with moving air or having a gas exchange, their sentences will be complete. Respirations will be unlabored. So this is the tool that you'll use. So the nurse, we use clinical judgment to interpret the patient's unique situation. We want to consider all that's going on with the patient, airway, breathing, circulation. We want to even consider their safety. So if it's a complex situation, if we sift through everything, and if it's something going on with that airway, this person's mental status is deteriorating. We want to gather that information, and then what's going to be our next steps? We're going to do what? We're reporting it, right? So further assessment, we want to ensure that we do further assessment, consult the healthcare provider, and then allow for that tailored approach. We have to, even if the UAP comes and say, hey, patient in room 201, they're saying they're having pain. Okay, that's good that they're letting us know that. We have to go and follow that nursing process, which means we're assessing. Even if we go in and assess, and for example, we get a blood pressure and it's abnormally high or low, is not where the patient's blood pressure usually is. We want to verify that information also, because our next thing is we're going to report this information to that healthcare provider so they can give us our next steps. Okay, let me read through this right here. We're going to assess for safety. Think about, is this a complex situation? Is this person deteriorating, or is this person's normal status? Further assessment to ensure that safe care is being given. We want to consult the healthcare provider. We want to allow for that tailored, unique approach. Ensure that we are not delaying actions. The nurse must use clinical reasoning to notice change in mental status. Is this confusion? Is this the same as the person? Is this person's baseline? Or is there's an increase in confusion? Is this person usually easily aroused by my voice, touching, or is this person barely aroused? Okay, so is this a fever, but we've given pain antipyretic, And now this person still has a fever, but it's less than what it was. So we want to say, is this something different, or is this continue, is it improving, but it's not back to normal? So we do want to interpret and then note if there's a potential for acute deterioration related to airway, breathing, and circulation. Think about all those airway disease processes. We just listed, and you all just stated all those things that we do to assess the airway to determine whether or not there's a problem or not. And then we want to respond appropriately. Assess, verify, and then we're going to report to the healthcare provider. Any questions about that? Okay. So critical thinking is in nursing involves purposeful, evidence-based decisions. You all just walked us right through it. As I asked that first question, you said, "Hey, we look at airway, breathing, and circulation." I put some substance to it. Well, what do you mean? How do we assess a person's airway, breathing, and circulation? What are some words? You said shortness of breath. What are some disease processes? This person may have asthma. Checking respirations, looking at that chest rising and falling. If they have pallor, is this a new change or not? What can the nurse do to gather information for the next steps? What aligns with the nursing process and the scientific principles? What's that acronym? ADPI. You all just started us off on assessment. The nurse should engage in evidence-based practice, which is meaning we're supposed to be assessing first, because that's that process. And then, which is crucial for providing that optimal patient care, because ADPI guides us through not missing a system, doing a head-to-toe comprehensive assessment. We know the comprehensive in-depth is for the RN, but we use the head-to-toe format so we won't miss anything. We make sure we check airway, breathing, and circulation. We determine if this is critical, chronic, acute, if there's a change. Any questions so far? We hadn't even got into our information yet, but I want you to be thinking this is what we're going to review each time as we move forward. Because it's critical that we make sure that we understand what we're saying when we say assess airway, breathing, and circulation. Priority. Okay, so assessing the client, we want to assess the client, because you all just told me the nursing assessment starts with assessment. We're going to verify that data before acting. If we're using a automatic cuff, even if we're a blood pressure cuff, get an abnormally high low reading, we want to verify that just to ensure. What can we do to verify that blood pressure if we're using an automatic cuff? What can we do?
Check it manually.
Check it manually. And what else? What's another thing that we can do?
Check the medical record of past blood pressure readings.
Okay. We stepping it on up. We're doing that critical thinking process. We're going to get to that part. We're going to identify if there are any trends. We can check it manually. We can get another blood pressure cuff, because sometimes those cuffs, once we open them up, really that little paperwork that's in there, it says it's only supposed to be pumped up, inflated so many times. So over time, those things do wear out. We can get another cuff, manual cuff. We can also get another coworker to come in and verify that. When we check in pulse oximetry, what are we have 10 fingers, we have different sites that we can, and then the toes, we can actually assess just to verify. We want to step back. Well, this thing is saying this person's O2 sat is 80%. They're talking to me with completing sentences without any problem, that chest rising and falling, and so forth and so forth. Okay, seeing some example, we just talked about vital signs. Pain. Person said they're complaining of pain. How do we further assess that?
Ask them what it is on a scale of 1 to 10. If they can show us where it's hurting, what kind of pain they're feeling, like if it's throbbing, if it's shooting, if it's intermittent.
Great, exactly. What were persons, they said that they were bleeding. The UAP come back and say, hey, person in room 201 said that they were bleeding from the site that they actually drew blood from a few minutes ago or earlier today. What would we do?
Go in and apply pressure. Put a bandage on it.
But before applying pressure, what are we going to do?
Assess it.
Okay, look at it and see if it's really doing that. What's really going on. Look, and we're going to assess and gather the data. In the event that there is really active bleeding, Of course, and our next steps would be to apply that pressure. Exactly. All right. We would not call the healthcare provider before an assessment is done. We have to go in and do that assessment. That is that purposeful, is that nursing process, is part of critical thinking. We are purposeful, is ordered so that we won't omit anything and so that we can provide that optimal level of care. Someone mentioned this. Look back at the patient's blood pressures prior. Look back at their how often they've been complaining of pain. Look back and see what's another thing? What have their finger sticks been running? So analyze and see if there are any trends. I noticed, the patient, I've been giving this patient pain medication every shift. I've been on shift the last 3 days. This is the third day I've had to administer pain medications, always around this same time of day. There might not be a trend, but still go and start looking at that. Any questions so far? Critical thinking and clinical judgment. That nursing process guides us. Okay, we just said this. Analyze trends and discuss with the team. Blood pressures, are they running the same? Are they high and lower? Do we notice a change in a certain time of day? Finger sticks, the same thing. Even if we look at lab values, they call them in, or if we're just looking at that patient's medical record and we're just looking at, what did their CBC, what was those values? We're actually critically thinking when we're looking at that, because more than likely, when we're looking at the report, we're looking at what the patient's values are, and then we're going to scan over and see what the norms are. Even if it does have that little H or the L there indicating high or low, we still look at what, how does this patient fall? We may even look back and look at the previous result. That is critical thinking. If we're looking at lab values, x-ray reports, if we're looking at the finger sticks, the blood pressures, that is critical thinking. We're analyzing those trends. So as we move on in, remember, we want to provide the best care we can to our clients. We want to provide optimal care. We have to think about, it doesn't matter if we have 3 patients in room 201, 2, and 3. They all have hypertension. We still want to provide that individualized, unique care for those clients. So, and we want to know as much as we can about our clients, because that helps us to be culturally competent and also to provide that individualized care for our patients. Clinical judgment requires adapting to the protocols on patient-specific responses. So, for example, like I started off, I told you all about these PowerPoints. I like to change them, mix up, and add a little bit more color to them, or pictures or things like that. That's adjusting to my learning style. Initially, I showed you the schedule on the syllabus, and then I showed you it in the modules. No matter what your learning style is, I showed both. So I'm adapting that to the student-specific learning style. So again, we want to provide care to our patients that are specific to them. We want to not assume, make no assumptions. We do want to establish those therapeutic relationships early on. Have those conversations. Seek to understand and learn more about the patient. So as we plan and collaborate with the RN on and getting ready to do these interventions, implement them, we can, before we even get started with one. Okay, this patient are, they say that they prefer eggs every meal, or they prefer coffee every meal. So because we understand that about that patient, we already know we need to get dietary in to have an additional conversation so that a nutritional diet can be provided for this client. So make no assumptions. We want to seek to understand and learn more about our patients so we can provide that individualized care. And that is part of being culturally competent. Any questions so far? So again, another test taking tip. When you say, if it only asks you if priority, I know I mentioned this last time, but I'm just going to keep reminding you, if it's a priority question and it does not say select all that apply, then when you look at the answer choices, several of those answers are things that we can implement or do, but it's asking you which one is best for right now or first. When you have multiple choice, read each answer carefully. Remember that only one answer is correct. If it's not saying select all that apply, there is only one correct answer. So, and just think about your scope of practice. We're going to talk about that. The Nurse State Practice Act, whatever state you're in, those are the things that we can lawfully do. Is on our to-do list. We can do those things. And we'll talk more about how sometimes professional and personal ethics may bump heads, but if it's in that state and it's in our scope of practice, we can perform whatever tasks those are. So as you are reading through, ask yourself, hey, is this for the RN to do? Is this for the UAP to do? Or is this for the PN? Okay. Priority questions, all answers might be right, but only one is best. Think, if I can only do one of these, which is the safest and the best for this client at this moment in time with whatever the assessment findings that you have found for this person. So remember, we're thinking about like that LPN, the PN, we're staying within our scope of practice. Okay, this is just another way of looking at everything, which we just said. Is this an acute, chronic? Is this person's baseline? Are they always confused? Are they always just oriented times one? Or is this new for them? Does this patient always in pain, but then they're complaining of more pain than usual? Or is it a different site? Is this a potential risk, or is this actually something that is real? For example, a person can be at risk for altered skin integrity. There's no break in skin. But if that person has a break in skin, that's actually altered skin integrity. It's not at risk for anymore. And then also consider if it's expected for that disease process. So if a person has COPD, it's kind of expected that they may be having some trouble with that gas exchange, because that's part of having COPD, problems with that gas exchange. Now, can that process or those findings exacerbate or get worse? Yes, they can. So we do want to keep that in mind as well. So you can visualize. You want to put things within perspective of time. Is this right now? Or did this person complain about this 2 days ago? Or is this 5 days post-op? So just be thinking about that. You mentioned ABCs. The next thing is Maslow's hierarchy of needs. If airway, breathing, and circulation is checked off, they're okay. Then we look at those physiological needs: food, water, shelter. Okay, this is just another way of looking at it. ABCs and safety. Pain, just another way of looking at what you all just said. Okay. Which patient will the nurse take care of first? So you already answered that question. Like I said, things will be repetitive, just in a different way. You always said whoever's having problems with airway, breathing, and circulation. Then I go on to Maslow's hierarchy of needs, starting with food, water, shelter. What should guide the nurse's decision? Well, we got to go and assess and then see what's going on. We want to verify that information and then go from there, reporting it to the healthcare provider. Airway, breathing, circulation, and safety. Airway and breathing issues are always the highest priority issues. You all have already said that. You were spot on. Okay, this is just another way of phrasing this. Okay. All right. So let me move this little thing back. To prove minimum competency, a beginning nurse must demonstrate ability to make appropriate nursing judgments. As we just talked about critical thinking and clinical judgment. We need to be able to recognize both expected and unexpected outcomes. Like we said, a person that has hypertension, when we measure those blood pressures, we hope that they are close to normal. But in the event that they are elevated, this person does have a diagnosis of hypertension. Doesn't mean that we're not going to take care of them, but it just means that we're just thinking. We're connecting the dots and seeing if there are any. All right. So let's look at our ethical responsibilities as a nurse. So what is, someone come off mute, what is client advocacy? What is that?
Speaking up for the client.
Okay. Does autonomy play a part in client advocacy?
Yes.
Okay. So let's put that, so let's make the connection. So a person says, that's my little timer. We're not at times as yet. No, okay. Person says, hey, I will go ahead and get that procedure done. They have consented to that procedure. And, we notify the healthcare provider. Is that client advocacy? Just notify them, hey, they want to have this procedure done. They want to move forward with this treatment.
Yes.
What about the client says, oh, I don't want that done? What if the client refuses?
And it's your job to make sure that the healthcare provider is aware.
Okay, great. What if they want alternative interventions or treatment options? What do we need to do?
You need to find out why. Oh, go ahead.
You're fine. Go ahead.
I was gonna say we need to find out why they don't want the treatment so that we can, because some people may be scared or not understanding. So we first need to figure that out and then go with the next steps.
What's the next step?
Then at that point, because if it's something that they're not understanding, we need to notify the healthcare provider to make sure that it's broken down in the correct manner so that they do understand what's going on.
That is the next step. You got it. So we do want to make sure that our patients make informed decisions, whether or not they're consenting or even if they're refusing. We still want to make sure that they understand, they're making informed decisions. In both ways, we do want to support them if they're consenting or even if they're refusing. Even if they ask for alternative options, treatment options, we still want to notify the healthcare provider in all instances. So we as nurses have a legal responsibility to report, even if we suspect and we don't really have all the details, anything that we think is unethical. So failure to report the act is a direct violation of the ANA Code of Ethics for Nurses, American Nurses Association. It violates that code. So we're supposed to just report it, even if we suspect it. And we're going to talk about us being mandated reporters here. It's a slide on down. So client advocacy is a key role of all nurses. The client's needs for advocacy often increases, especially if they're finding out they have a new diagnosis and also if they have an exacerbation. And so in either way, if they're consenting or wanting more information or they're changing their mind or refusing, we're there to advocate for them, notifying that healthcare provider. Accountability. The word accountability means that the nurse is answerable to themselves and to that assigned client and to their family. So we add the family in there because if the patient has a power of attorney and they have assigned someone to make decisions for them, then of course, we have to go with whatever decisions they make. Because remember those documents, DNRs, power of attorneys, living will, all those things are legal documents. And so we have to be accountable to those. Even if we go in and even if we know, if we suspect that, doing, chest compression is going to help this person, even if the patient decides not to go with a treatment option, and more than likely that treatment option will help that client. They want to leave AMA. We still are accountable, just making sure that they have that, make that informed decision, and we just support them in whatever decision they make. We can't just go in and do CPR and disregard that do not resuscitate order. Okay, so client safety reporting. Report peers, supervisor, or any team members for behaviors that are potentially harmful to the client. We just said that ANA, American Nurses Association, says, hey, we got to report it. We have to report it. System-based issues. Identifying system-based issues is essential to providing safe, high-quality care. Within your setting, urgent care, whatever setting you end up in, if you identify that, whatever the procedures that we're doing is slowing down patient care or it's just not effective, then we need to identify that, talk and have a discussion with, the supervisor, because that goes along with that spirit of inquiry. It is, can we provide the best care for our clients, keeping them safe so that client can have optimal out. Can we just do this a little bit different? Not to say that we're changing our scope of practice now. We're going to still be lawfully within our scope of practice. But sometimes processes may need to be reversed, a step may need to be flipped or something like that. So that's identifying those system-based issues. Because a lot of times facilities will say, they have these processes and they're good with them, but making that flipping step 2 to step 4 might be more beneficial for that patient. Time, resources, and everything. All right. So get ready to talk about who does what. The State Nurse Practice Act, remember, it defines the legal scope of nursing practice, and the whole purpose is to protect the public. It tells us what we can lawfully do within that state. So keep that in mind as you answer questions. Some questions going to ask you what should the nurse do? You need to go back and look and see, are they talking about the PN, the UAP, or are they talking about the RN? So the LPN makes nursing diagnosis or initial assessments. Is this true or false?
False.
LPNs make initial assessments. I wrote the same thing on that same slide. So you just said that was false. So what would make this true?
RN makes the initial assessment.
Got it. Good. Great. So RNs are educated to develop nursing care plans independently using all the steps of the nursing process, using those nursing diagnoses, those NANDA approved. The RN can administer medications under the direction of a healthcare provider with prescriptive authority. Not all healthcare providers have permission to give orders, And so the LPN can too. We can administer medications as well. This slide just speaking to the RNs. RNs are taught in-depth assessment skills, including that comprehensive physical assessment on all body systems as part of their basic education. So the RNs do this comprehensive, more in-depth. Look at those words. As LPNs, we do assessments, but ours are not as comprehensive and as in-depth. Okay? So there's some things that the RN and LPN can both do. We both can administer medications under the direction of a doctor that has prescriptive authority. Okay, so the RN, they're the ones that's making those care plans up, devising and coming up with that. Critical thinking and the nursing process are thinking methods, both used to solve problems. Go in, the patient's complaining of pain. Go in, the patient, so what we going to do? We're going to do our assessment, gather our data, our yes and no, get lab results. We're critically thinking. We're looking to see if those lab results are within normal range. Are they high or low? We're critically thinking. If they are within normal range, what's our next steps? If they're high or low, what does that mean for this client? So that's how our thought process should be. Critical thinking is based on principles and steps of the nursing process, again, and on scientific methods. Let me stop sharing. I see some messages in the chat. Make sure I'm not missing any questions. And then, like I said, a lot of this is going to be repetitive, and that's fine. Yes, if you're having connectivity issues, keep going. If you're having to step away to the restroom, great. Thank you. So all of this is just rewording it and showing to you in a different way, but it doesn't change what you know. Just like I asked initially, what determines if a person is acutely in trouble? You all say airway, breathing, and circulation. Then I asked you, well, what does that mean? Someone has problem with the airway. You said shortness of breath. You told me, you gave me more information. Good. So critical thinking and nursing process are thinking methods, both used to solve problems. Okay, so now let's look at assessment, diagnosis, planning, implementation, and evaluation. Who does what? So for the assessment, we both go in and gather that information. But we said the RN does a more comprehensive, a more in-depth assessment. Okay, diagnosis, we said the RN come up with that based on NANDA. Those nursing, not medical diagnosis. So medical diagnosis would be like hypertension. NANDA calls it unstable blood pressure, but they're both like tomato. But hypertension is a medical diagnosis. NANDA says unstable blood pressure. That's one that comes to mind. So planning, we collaborate. LPN, RN, we talk about it. Well, hey, what do we think the best steps are? Remember, we've already talked to our patient. We have found out, we have understood, and we have not made any assumptions about our patients. We've gathered more information so that we can provide that individualized care to them, for them. Implementation, what are we going to do? We both can carry out orders, administer medications, put in Foley catheters, dressing changes, and so forth. Okay, evaluation. We report our findings. Then we determine if this pain medication do any good. The person is still complaining of pain, but now they're rating their pain as a 2. It was a 7. Temperature, person still has a fever, but the temperature has dropped from 101 to 100.6. It is improving, or the temperature went up, or this person pain is worse. Okay. Again, who does what? RN education includes developing nursing care plans using NANDA and follow those nursing steps, the nursing process. Both RN and LPNs, we can both administer medications. We can do dressing changes. We can insert Foley catheters. RNs are taught in-depth assessment skills. This slide is no different from the others you all. I just had some different little pictures on it. And I showed this to you to show that your information doesn't change. So when you sit down and read a question, you know what you know about that information. You know who does what in what part of the nursing process. Just because the question is reworded or paraphrased, it does not change who does what. Okay, the RN does an in-depth, more comprehensive assessment. Okay, both can administer medications under, so the RN has authority to delegate tasks. The LPN and RN both can delegate tasks. The LPN can't delegate to the RN, but the LPN can delegate to the unlicensed personnel. So both can collect data. So that's part of our assessment. Our focus is more on the basic information as an LPN. RNs is more comprehensive. So when we're gathering that information, assessment, the RN doesn't have to come in there with us. We can do that independently to go in and gather that information. Before collaborating on the plan of care with the RN, the LPN must assess the client's understanding first. We're going to make sure that this client understands. We're going to seek out to find their learning style, find out more information about the client and what's important to them. Do they want to know alternatives? Do they want to know just what the most highly rated treatment option is? Or do they want to know, several options? Okay. The LPN, we most often reinforce the client teaching, and we notice changes needed for the plan of care. As we implement these interventions, we start noticing that, okay, this patient, their pain is less. They're saying that, they're not in as much pain. We start noticing those changes. Nursing interventions are patient specific, individualized. What's another word? But nevertheless, it's specific for that person. The person in room 201, 202, and 203 should not have the exact same care plan. Interventions. They may have the same nursing diagnosis. For example, it could be unstable blood pressure, but their interventions more likely going to be different. Check vital signs. One person's might be to administer pain medication, might be to administer antihypertensive. It might be to encourage the client to, what are those? Non-pharmacologic interventions. Encourage this person to cough and deep breathe, or remember or go through relaxation techniques. And I add pain medication in there because a lot of times the patients are in pain, and we do know that does affect that person's blood pressure. All right. So we do know. So let's discuss some tasks that the unlicensed personnel can complete. Come off mute and just tell me. Give me 3 tasks that the unlicensed personnel can complete.
Vitals.
Okay. So they can collect vital signs. Can they interpret, oh, this blood pressure is high, this blood pressure is low?
No.
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 Okay. What's another task that a UAP can complete?
They can't do blood sugars.
Okay. What's another task?
Assist with bathroom or assist with making sure getting their ADOs, things like that.
Got it. Great. Keep that in
INOs.
mind. We said vitals, yes. So as the RN feeding, thank you. So as the RN is coming up with the plans, things need to be measurable and they need to be realistic and time specific. And so as you all are coming up with your care plans, as you all continue out in your clinicals, most of you all use, what's the name of that care plan book? I know we use it. I can't remember who the authors, but it's real good about having realistic interventions. It considers the age, it considers the setting that people are in, because some things you can't do in the urgent care that you might can do at this patient's home. So we want to make sure things are realistic that we're planning to do for this client. So subjective and objective. Give me examples of subjective information, you all.
Someone saying their pain is a 7.
Okay. Give me another example.
It's burning. I don't think you can
How they're feeling.
measure burning.
Okay. How they're feeling. They're describing, giving descriptive terms as, what that pain feels like, burning, throbbing, on and off, whatever that. So what about objective? What is that information?
Things you can
What the
see.
nurse sees.
Or
Okay.
vomiting.
Okay. Got it. Good. Those are good examples. Critical thinking, scientific principles. We're collecting data. Remember, critical thinking and clinical judgment are ways to solve problems. We use that nursing process, collecting data. That's just assessing. We're verifying that data. We're still part of assessment. We may have to get a manual cuff or another cuff or change the sites if we're checking O2 stats. We want to arrange that data in an organized way. Someone said, look for trends. You all said that earlier. And then look and see if we have any gaps in the information. We do have this order says check the vital signs or blood pressure every shift. But when I do the printout, it's only showing me vital signs or blood pressures for the first and second shift. We're missing information. And then once we have everything, we're going to look at it and analyze it and see what does this mean, and then move forward with implementing and come up with next steps. We just said this critical thinking and the nursing process. You can't get whoever came up with these terms for it is just beautiful because it helps us to solve those problems for our patients. It keeps us organized. Critical thinking is based on the principles and steps of the nursing process, ADPI. For example, making judgments based on evidence rather than guesswork, because we're going in to assess this client. Even if the family member comes to the desk and say, hey, my loved one said that they have a headache. We're still going to go in and gather evidence, the facts. We're going to ask those questions so that we are and going to verify them. We're going to report it to the healthcare provider. All right. So the nurse must use clinical judgment to interpret a patient's unique situation, considering all that's going on with that client. If there's, and we're going to say, well, hey, is there a need for further assessment? Do we need to consult that healthcare provider? Because that's going to allow us to give those specific patient unique answers or interventions. Or should we just go in and just administer medication only? Administer medication and further assessment and notify the healthcare provider. We want to ask ourselves, is this patient deteriorating or is this the normal for this client? They usually are confused. Are they more confused or is this the same confusion as normal? Again, same thing again. Calling the physician after the assessment. We want to go in and gather that information, verify that information. That allows for that healthcare provider and allows for us to report the most recent. Now you can go back and report how it was an hour ago, 30 minutes ago, but it allows us to report that most recent information about that client because people can change quickly. And then we want to address life-threatening issues in an appropriate manner. We don't want to be just bebopping around. Even if we call that doctor and they're not responding, are we just going to sit there and just wait on them to continue not to respond? No, we're going to reach out to our supervisor and say, hey, we have this going on. We follow the procedure to notify the healthcare provider. We are not getting a response. We need some actions. We need our next steps like now. So, and then more than likely there's an alternative to contacting someone for coverage. Okay. All right. So critical thinking, we want to provide optimal patient care. We want to provide the best care for our clients. So we got to be critically thinking all the time. The nurse should apply the knowledge and skills that you have. You've learned from med-surg, P's, all of these different classes. You have that strong foundation. You know what's a normal respiratory rate. You know what COPD is, hypertension is, and so forth. Apply that knowledge to the what you're seeing going on with this client, the information that you're assessing and collecting. All right. And so you want to include observing, analyzing, and planning, engage in evidence-based practice. That's following that ADPI, going through the nursing, using those nursing diagnoses. And we say analyze those trends. Is this the same thing for our client, or is this something different? Even if it's something small, y'all, and I have a slide on this too, those small changes, all of them are important. Well, patient in room 201, they usually are alert. They usually eat all their breakfast. Usually lunch and supper are their lighter meals. Notice they didn't eat breakfast today or yesterday. Those, even though they may have eaten that small change, they're not eating as much, or they're coming out to activities. They're usually the first ones there. Lately, they're getting to activities when it's almost over. All that information is part of our assessment. So, okay, we said this right here to talk about the nursing process. Here we go. Systematic approach keeps us all aligned, collecting that information about that patient's health status, diagnosing, analyze the assessment data to identify the patient problem. That's that NANDA that the RN is coming up with. We're planning. What are we going to do for this client? We're providing those individualized interventions. We have, we know we're advocating for our clients. We know they have the right to consent, refuse, but we want to make sure they make an informed decision. Nevertheless, we're going to let that healthcare provider know. So as we're doing these interventions, we're gathering information. Is the blood pressure the same? Is the pain the same? Is it worse? And that helps us doing the evaluation part to assess the effectiveness of what we did, that intervention. And then we can modify that care plan as needed. We can resolve it. Patient pain is gone. Or, we're noticing that this client every day at 3:00, they're saying they're in pain, but the next dose is not due until 5:00. So after we assess and gather the information, we analyze to see if there are any trends. We're going to notify that healthcare provider. More than likely, this client may need a change in dose, a change of medication. They may need a breakthrough pain medication. They may need some pharmacologic interventions. Okay, here we go. Critical thinking. We need the nurse's awareness of subtle behavior changes is an example of noticing. Remember Tanner's model. First, we're noticing. No thing is too small. Identifying those cues and patterns that will signal a change in the patient's condition. And you all probably have seen it. A lot of you all work in healthcare settings. You've been in clinicals where you've had that same patient. You're like, wait a minute, they were not like this yesterday, or they were not like this last week. They're different. So that's identifying those subtle changes. You all said this. Airway breathing issues are always the highest priority. We want to address the acute changes in a patient's condition. So as we're stepping back and looking at our client, we're like, wait a minute, is this the same? Has this client always been confused? Or this is new for them? Does this client always complain of, pain at this time of day, or is this new for them? All right. So critical thinking, while evidence-based protocols guide practice, clinical judgment requires us adapting those protocols to that patient-specific, so we can have that patient-specific response. Because remember, we provide that individualized, unique care for that client. So this slide is saying the same thing, but look how the information is coming in as a different way of looking at it. Interpreting using patient data, comparing it to the relevant theoretical and experiential knowledge. What do you know about this disease process? What do you know about blood pressure measurements? What have we said the norms are? Okay, we're looking at what this reading that we've gotten from this patient. Is this normal, abnormal, high or low? Where similar information, make sense of it. Is this high or low? Identify if there's any issues. And then what's our next steps? Okay, let's look at some critical thinking here. I think we noticing a change in the patient's condition, drop in blood pressure, change in mental status, assessing the client. Go back. I think I got a little bit too fancy on this slide. Assessing the client's vital signs prior to giving a medication. For example, antihypertensive, measuring that blood pressure. If we're giving heart or cardiac related medicines, we want to do that quick cardiac assessment. Heart rate, blood pressure. If we're administering a respiratory medication, we want to do a quick respiratory assessment. O2 sat, counting those respirations. Noticing those changes in that patient condition. Said that. What about if we're questioning the medication order? That's unusually high or low. As you continue to administer medications and see orders, you'll kind of be like, wait a minute, Tylenol is 1, 325, 500s. Although now they have all these other different types of Tylenol. I think they have like 2 doses in one and all of this. But nevertheless, if you are wondering whether or not this medication order is correct, we need to verify that information. That's part of critically thinking. And then we want to prioritize that patient's care. Okay. Asking that client their pain level. Like we just said, we're going to administer all things cardiac. So we're assessing that cardiac system, blood pressure, vital signs. We're listening to their heart sounds. If the person is complaining of pain, we're going to assess that pain, do a more focused assessment on their pain. The same thing for all things respiratory, what we just said. Listen to the respiration, the lungs, counting their respirations. Look at that chest rising and falling. As your patient is talking, are they completing sentences without having any trouble? Or are they having to gasp for breath every other word? That helps. That's part of that assessment. So determining that a pain medication is not adequate for a patient post-op. These are just taking what we just said a little bit further, giving some scenarios. We're reviewing the lab values for a client. Or say, patient's H&H is high, it's low. We're going back to our foundational knowledge and we're evaluating that. That is critical thinking, you all. It's critical thinking. The nurse must use clinical reasoning to notice increase in confusion, fever, interpret what does that mean, and then we need to respond appropriately. Well, we just said to take it a step further, musculoskeletal. We're administering a medication for a musculoskeletal disorder. We want to do that focused assessment, pain, mobility, all those things, musculoskeletal. We already talked about respiratory, doing that focused respiratory assessment. Should have been more on this one. Oh, so this slide just has notifying the provider, ensures timely intervention for the change in the condition. We go back and we assess because we want to give that healthcare provider the most recent information. We can give them the background, but we have to assess and notify that healthcare provider. I thought I had something else on that slide. So restacking tasks by reassigning non-urgent duties allows a nurse to focus on patients' acute needs. So this is delegation. We'll talk more about delegation here. I want to say it's our 3rd exam, but what it does is even if you're that team leader, you're that charge nurse, and you're assigning tasks to other nurses, it's not so that you will have less patience as the others. It's just so that you can free up some of your time to complete those tasks that you cannot delegate to others. So this is how you've gained your knowledge. Go all the way up to A&P. You learn those body systems, bring it all forward. You learn what blood pressure means. You learn what cardiac medications are supposed to do. How does pain medications and things work? So when you go in and you have this client that has hypertension, that has pain, that has COPD, you're having to look at that whole client and break down those complex parts and figure out what you need to do to take care of that client, that whole client. Because we can't just go in and work on the patient's blood pressure and not address their pain. We can't go in and address the patient's pain and not address that they need assistance from the UAP for bathing or eating. So we have to look at the entire client. That's that analysis part. Okay, these are just some examples. Knowledge we're just recalling as we're looking at lab work, we're critically thinking. This patient's potassium is 5.5. What does that mean, you all, for that client? Their potassium is 5.5.
It's high.
Okay, it's high. And so what are our next steps? What does this information mean for this client? When we are assessing, we might have some assessment findings, some S&O, that now that we have his lab, that's probably why they were complaining of such and such. So what do we do with that information? Okay, we notify that
Tell the
healthcare.
provider.
Got it, Miss Virginia. Great. So Tanner says, hey, as you're in assessing, as you're interacting with your clients, at a minimum, we go in every 2 hours to assess our clients and do the next step. If we're at the top of the hour, y'all, we need to stop and take a 5-minute break. We will get through all of this information. Remember, this video still plays, so turn your cameras off and put yourselves on mute. We'll see you in 5. So it is, it's 9:01. So see you at 9:06. See you soon. All right, let's keep moving. All right, so Tanner wants us to notice Tanner's model, and we have all these different models in nursing and in healthcare that just guides us as we are taking care of our patients and coming up with resources, developing resources and everything. So Tanner says, hey, you got to notice what's going on with your client. And that's part of that assessment part. No matter, even if it's a small change, we talk about those subtle changes. And then what does that mean? So we're interpreting what's our next response? And then reflecting is sort of like the evaluation piece. Are we like, what we did, what we noticed, did it make sense? Is this acute, chronic, something going on with this client? And then our response, the interventions that we implemented, did they work? So noticing no changes too small, identifying those cues and patterns that signal a change in the patient's condition. Interpret, what does this mean? Interpreting uses patient data and compares it to relevant theoretical or experiential knowledge. So then we're like, again, on this part right here, we're saying also, is this acute or chronic for this patient? Is it expected? This client has, what's another, let me just call it another disease, chronic disease process out. Irritable bowel syndrome. Is it, kind of a norm until those patients get uh, settled, so to speak? Is it expected that they'll have numerous bowel movements? So is it expected or unexpected? Fever is never expected with this stuff. That's critical. That's something that we need to be responding to. Interpreting uses patient data and compares it to the relevant theoretical and experiential knowledge. The nurse then begins to assemble all the information, make sense of it. Is this expected, unexpected, or is this chronic for this client? Are they always like this? Identify those issues and establish priorities for the care. So we're sifting through everything that's going on. We use ABCs, we use Maslow's hierarchy of needs, food, clothing, and shelter to prioritize our next steps for that client. Okay, so now we're going to look at ethics here. Ethics is a system of standards or moral principles that direct actions as being right or wrong. What actions are right or wrong or correct or incorrect. Ethics is concerned with the ways people either individually or as a group decide to do the following. Should we do this or we shouldn't be doing this? Do we have a duty to do something? For nurses, what does our state practice act say? Can we lawfully complete these tasks? And if we can, despite our personal feelings about it, lawfully we can. Now, in the event that, and we have a slide on personal ethics here and professional and personal ethics here in a moment. If they bump heads, remember professionally, we can complete that task. But, that would just take us sitting down with our supervisor and, conveying that information. They may still ask us to still complete the task. And sometimes they'll actually substitute. We may can change out or swap a task with another team member. But nevertheless, lawfully, we can complete those tasks because that's what our state nurse practice act says that we can do. Those are the things that we can do to practice within our scope. Okay, we talked about being culturally competent. We want to provide that individualized care. We don't want to make assumptions and assume that because this client has diabetes type 2 or 1 or whatever, that they're automatically on finger sticks, every day or 3 times a day. We don't want to assume that this client understands what that disease process is. We want to make sure that we establish those therapeutic relationships, gain understanding about our clients, see what their learning styles are. We want to develop them or change, or not really change, but make our interventions comply with their learning style. We may have to show videos. We might have to have things printed out for them on paper. A lot of times we go in and we reinforce teaching, but having that paperwork so people can jot down or have it in their email or whatever they can refer back to, it does help. So we just need to know more of distress occurs when a nurse knows the ethically correct action. They know, but they feel powerless to act due to institutional or legal constraints. And so it kind of goes back to that other slide where we mentioned identifying those systems. If they're broken, if our systems that we're working in are broken down, we work in the urgent care, and we can really get these patients out here or make better use of their time by giving them the questionnaire. Or I know we have that kiosk out there, but people are taking so much time trying to figure out what to punch and click and all of this. Maybe we had a person also sitting out there that can assist them, if they have questions, rather than just keep punching buttons. Because our patients, they're spending more time trying to figure out how to log in or to register than we are back here assessing them. So personal versus professional ethics. Personal ethics can provide personal guidelines for living. Is it right or wrong? What should we be doing? You ultimately choose your own personal code of ethics. Your personal code of ethics will also influence your nursing ethics. That's the example where I just gave, where the State Nurse Practice Act, our scope of practice says we can complete a task, but then personally, we might not want to. And so, we would just have that conversation with our supervisor. But lawfully, we can provide whatever's in our scope of practice in that state. And the scope of practice is not one state for all. It's whatever state you're in, you need to provide according to that scope of practice. Ethical nursing practice requires placing professional values before personal beliefs. Because remember, when we clock in, we're clocking in as that healthcare provider. And remember, our state nurse practice that guides what we can do, our scope of practice. Professional values must guide nursing care even when they conflict with personal beliefs. If it does, you can take it a step further and have a conversation with someone in that healthcare facility. And they may say, hey, I appreciate you letting me know this, but your scope of practice in this facility in this state says that you can do this, and this is what you're expected to do. Now you might decide, hey, I want to change my work setting, and that's fine, because personally you don't want to engage in whatever task. Okay. We looked at, I think I had the exact same slide I did. I thought I changed it up a little bit, but let's just read back through. We talked about client advocacy, advocating for those clients. Either they want to consent or refuse. Either way, if they want alternative treatments, they want an option. Most of the times the healthcare provider has already looked up their, statistics on, whatever the disease process is and the treatment option. So usually they will pitch whatever based on the evidence, the better findings or outcomes for the client. So that's usually the treatment option they'll recommend. But if that client wants more than one option, notify that healthcare provider. They come back in and give them some more information. Whistleblowing is a professional obligation when patient safety or legal violations are at stake. We were talking about whistleblowing, I would say here last term, was a couple of terms back, where people, is where you actually literally blow the whistle. You tell if something's going on in your organization that is wrong. If they're having UAPs practice outside of their scope, if they're having the PN practice outside of their scope, whatever it is, there was legislation that protected the person that blew the whistle. Reporting through proper chain of command protects both the patients and the nurse. Okay, autonomy, we talked about this. Individuals have the capacity to think, and based on those thoughts, they can make those decisions freely, whether to seek health care or not. They have the freedom to choose. These clients want to, patient in room 201, and I pick on patient in room 201. They want to leave, we're working in the emergency room, and even if they're on med surg and they're ready to go home for whatever reason. They want to check out against medical advice. Is there a question? Did I hear something? They're wanting to leave the facility against medical advice. We give them all the information they need to make an informed decision. But if that client decides, hey, appreciate the information. I understand. I still want to leave. We notify their healthcare provider and we give them that paperwork. They have the freedom to choose. Autonomy is advocating for the client. The nurse should contact the client's physician and encourage the client to tell their family about whatever decision that they've made, especially if that client has a legal document. And now the patient don't have to. We can just encourage them. They don't have to. But especially if the family members are questioning what we're doing, we can't violate HIPAA, but we can encourage that client to say, "Hey, you might want to share with your kid, your family, because they're questioning, what we're doing, and so it's okay. That client might not tell the family, but still we can't go beyond our scope of practice and we cannot violate HIPAA. So it advocated for the client. The nurse should contact the doctor. And then we want to just check in the chat. And then we want to, okay. We want to contact the doctor and let them know and encourage that family member, to just let their family know these are their wishes. Because a lot of times you'll get family members that think like, you just not doing anything for my loved one, or I just don't understand, or they'll just keep asking all these questions and we cannot legally let them know. And so, hey, you just want to might let your family know, what you decided what your treatment option is. And if they do, they will. And then sometimes they won't. They'll just, tell you, hey, I don't want to share that with them. We've encouraged them to, and we just go with whatever they decide. Respecting the patient's right to make informed decisions about their own healthcare, even if it conflicts with the healthcare provider's recommendation. So I think we're going to talk about this, beneficent paternalism. The healthcare provider has come in, and I think the example that I gave you all last week was the patient says, yeah, I just signed that consent. I just went on and signed it. I just signed it because the doctor was in here talking. But really, I don't want that procedure done. It is on us to make sure that client has all the information they need to make that informed decision. If they change their mind, we let that healthcare provider know. Even if we're rolling them, we're getting them on the elevator, taking them down to the OR. If they change their mind, they signed off on the consent. They have the right to change their mind at that moment in time. Do a patient have a right to consent? You can come off mute and say yes or no.
Yes.
Do a patient have a right to refuse?
Yes.
Do a patient have the right to ask questions about other treatment options or alternatives?
Yes.
Yes.
Great. Okay, so beneficence involves acting in ways that promote the well-being of patients, including providing beneficial treatments and interventions. Is what I'm going to do for this client, are these interventions that we're implementing, is it going to benefit this patient or not? So we want to keep that in mind. We don't want to cause this patient any harm, non-malfeasance. So that should guide us as we are, talking and collaborating with the RM when they were talking about these interventions, and as we are determining whether or not, we're discussing our findings or our responses to the interventions when we're doing the evaluation piece. And this client seems like they're complaining of more pain since we started, this medication. Because certain medications might not block those receptors. So this client might need to be put back on their other medicine or a different medicine. So we don't want to do the client any harm. Justice, no matter our pay status, no matter of ethnicity, we provide the same care to all of our clients, which is we provide that best care to the clients. Fidelity, change challenges each practical nurse to be faithful to the charge of acting in the client's best interest. If we notice our coworker taking the client's medication, that's a criminal act, in that client's best interest, we need to report that. So this is just looking at it all again. Autonomy refers to respecting the patient's right to make informed decisions about their care, even if it conflicts with the healthcare provider's recommendation. We said beneficent involves acting in ways that promote that well-being. Now, malfeasance, do no harm, justice, fair, equal. And this right here, we added some little pictures with it. Same thing. Same thing. Okay. So legal aspects of nursing care, the state statutes that apply to licensed persons in situations in client care that could result in legal action. Where can we find them? State Nurse Practice Act. Because remember, that tells us the things that we can lawfully do. Then our organization, if we're working in the urgent care, the hospital, home health, we can look at that organization's policies and procedures in their rules and regulations. Those things that the urgent care, the hospice facility, or whatever, they should match our Nurse Practice Act. They should not be asking us to do things that are not in our scope of practice. Now, does that mean that they might? They might. They might. So it's up to us to know. I'm just checking the chat what is in our scope of practice. But generally, they mirror the organization's rules and regulations, the organizational policies and procedures, urgent care, hospital. They're going to mirror what's in the state Nurse Practice Act. These are the things that we can lawfully do. Okay, where can we find those minimal competencies? State Nurse Practice Act. It's important to know your scope of practice. So the Nurse State Practice Act functions as the state board's nurse general provisions. It has all of these things listed in there. It tells us the number of continuing education hours. Now, you all signed up. We signed up to be life learners as healthcare providers. We're always getting that latest evidence, so we can be giving our patients the best options for their care. In the event that a nurse ends up impaired, they have a program. They rather you come to them than, something happened to a patient and you be forced to go to the impaired program. But they have a bunch. The National Association of Licensed Practical Nurses, they have these organizations for every kind of healthcare provider there is. And these associations, these professional organizations, they expect for us as nurses to follow what those rules and regulations are. For example, HIPAA, maintaining that confidentiality. They expect us to maintain that patient's confidentiality. No matter how many times that family member come to you asking you about that client's information and they're not listed and we don't have permission to share that information, we shouldn't share that information. It's expected that we keep it private. Let's see. The National Association of Licensed Practical Nurses, this ethical principle, keeping things private, HIPAA, is fundamental in nursing practice and is consistent across various nursing codes of ethics. LPN, RN, ostomy nurse, because you have all these different specialties. Maintaining that confidentiality is crucial. We want to protect that patient's privacy. That client is expecting us. We've established those therapeutic relationships. They trust us. They trust us to do the right thing with their information, to advocate for them, to support their autonomy in them making the decisions that they are making. So this is looking at the state board, nursing functions. They say, hey, I know your classes are different times. Certain classes you had to have so many clinicals. They tell us all of that. They tell us how much seat time we need for this class, how many clinical hours, so forth and so forth. So they carry out disciplinary actions for violators. They decide, well, hey, the nurse can keep his or her license or take it. They decide that board. And also LPNs can sit on your state board. If that's your so desire. If I do something wrong, the nurse does something wrong, what are the next steps? And we talk about disciplinary. A complaint is usually filed to the state board. Family members, patient, they can file directly to the state board. That complaint is reviewed. An investigation is done. That's gathering all the information. Board proceedings. This is where the nurse has the opportunity to respond. Settlement, administrative hearing, or there is some type of disciplinary program. Okay, that board action. In the event they deem it emergent to protect that public, they may shut down that facility. There have been facilities where they've had to relocate patients, or that nurse could not work on a shift without a certain amount of supervision. There have been instances where people had to pay money. Licenses were revoked, taken, or that nurse might have been on suspension. They, remediation. What can we do so that this act won't happen again? We need to review the scope of practice. We need to review, medication administration and things like that. So we have these databases that house. I like to look at them as huge file cabinets or containers that have the nurse's information. It's a national database, and so the facilities, they look in just to verify that this person has a license. Now, I don't know you all about the people working as nurses and all these healthcare providers as doctors and things that really wasn't. I don't know that how that happened, because they do have these databases. So I'm not sure. We've been hearing, I want to say since like December. Miss Hunt, Miss Hunt, can you hear now? It might be your connectivity. Oh, she fell off, so that's probably what it is. Yeah, if you can hear us and then you stop, it's probably your connectivity. Maybe just log back in, log off and log back in. And if it's weather in your area, you just never know. I can't answer to, what happened with the people that were acting as doctors and all these different people and we're actually seeing people. I don't know. But nevertheless, we do have these databases. So wait until you either get your temporary license or your real license. Don't go out there checking off on that application, you all, that you are licensed in that state and you have not received your temporary license and or your permanent license. So wait until be truthful about that. You're just out of nursing school. If you're going to apply for those temporary license, wait till you actually get your paperwork and the stamp of approval and then work on those, not before then. Okay, because otherwise you're imposter. Because what are you working on? You're not working on your temporary or your permanent. So when they look you up, they don't tell you, your date of birth. They don't tell where you live and all that information. It just has who you are, your license number, has that license expired, and then if you have any disciplinary actions or not. Again, I don't know how those healthcare providers that were really not healthcare providers, I don't know how they ended up with all this stuff. I don't know. Liability is being responsible for something. We're going to get ready to talk about this negligence in a few minutes. Liability in nursing is associated with civil law. It includes contracts, negligence, intentional and unintentional torts. So we're going to talk a little bit more about that. Okay. So criminal law provide proof beyond a reasonable doubt. Felony could list it as a felony or misdemeanor. Crimes such as homicide, larceny, or embezzlement. Leave these things alone. They don't belong to you. Don't get the client's medications. Don't be messing with. They want to send you to the store with their debit card, all this. Don't do that. There's a procedure in that facility of how that client should obtain those things, because something, people have changed in mental status. You want them saying that the nurse was taking their card and buying all these different. There's a procedure for it. Okay, in those facilities. Criminal. Still in medication. Example, this is just one example. Still in medication is a criminal act and may lead to prosecution and loss of license. Defamation, making false statements that damages a person's reputation. Negligence, failure to act as a reasonably prudent nurse would that resulted in injury. So we have a slide on negligence here. So when they look at negligence, they look at, hey, were you assigned to that patient? What were you supposed to do for that patient? That's that care plan. It said that we were supposed to implement these things. If the patient sustains an injury, then they come back and look and see if there's a proximate cause. I'm going to fast forward to that slide. So what they're looking at is there a connection? And the nurse was assigned. The nurse did not follow the care plan. For example, the client was supposed to get blood pressure measurements every shift or before administering those cardiac medicines. The client was supposed to have two persons assist with transfers or one person assist in the shower. These are just some examples. And the client failed. They broke their arm or leg. They look and see, well, hey, because we did not do what that care plan said by having that one person there, two persons there, checking that blood pressure prior to administering that medication. Is it a direct connection between the damages that this client sustained? And if it is, we were assigned and we didn't do what the care plan says, and their person has some damages or harm, and they can say there's a connection, then we have been negligent. So if you're changing assignments, and this happens sometimes depending on patients getting admitted and discharged and transferred, it changes sometimes in the facilities when more staff come on. Staff, somebody clocks in or somebody leaves. You want to make sure whatever that facility's procedure is, you want to ensure that it shows your correct patients that you are responsible for. Because if something happens, they're going to look and say, was this client assigned? Was it the nurse's duty? Okay. All right. Then tort, a civil wrongdoing that causes harm leading to legal liability. And then sentinel events are defined by risk or occurrence of seriousness of what's going on to that patient that will trigger an immediate institutional investigation. A patient goes in for surgery and to get the right hip replaced, and they end up getting the left hip replaced. Like, why did that happen? Client goes in for amputation we'll just say the right pinky finger, and they end up with the left hand, amputated. Why does that happen? So that will trigger a institutional review. They'll come in, like I said, they may even say, we need to transfer these, shut it down. We need to transfer the patients immediately. They might. So those are things that should not be happening. That's not expected. All right. So intentional versus unintentional. An intentional tort is intended to cause harm to the client. There's an intent. They specifically intended to cause harm. Unintentional, I did not mean to. So we do want to take the time to follow that facility's policies and procedures, their rules and regulations, medication administration rights. They have this thing what they call a timeout. Where we stop what we're doing and we go back through. Is this the correct patient? Which arm or leg are we operating on? Which arm or leg are we amputating? Stop what you're doing just to verify. We mark that arm or leg, that extremity. Okay. When we don't take the time to do that and harm is rendered to that client, it can be considered as a sentinel event. They can shut the whole facility down. Malpractice is a type of civil law violation. Occurs when a nurse fails to meet the accepted standards of care and that patient ends up with some type of injury, some type of harm to them. Okay. All right. So this slide is explaining those four things again. Am I assigned to this client? Refers to the nurse's responsibility to provide care in an acceptable way. Before administering medications, how do we identify the client? What are the medication administration rights? Before I administer this medication, what's the medication we supposed to check the pulse first, you all, before administering? It's like a common one. What's the name of that medicine that we supposed to check the pulse first? Digoxin.
Digoxin.
Okay. Yeah, it came to us at the same time. So is this an acceptable way? We know that it is going to be listed there. Did we breach the duty? Did we not check that pulse first? Did this client end up going to the hospital, have an ER visit because, they had a low heart rate, change in mental status, they were admitted to ICU, they got better, but they came back. But did we harm that client by not following that procedure, taking the time out to do what we were supposed to do, our responsibility? If they can make a connection with all of this approximate cause, it means that we were negligent. The legal name for professional negligence means negligence by a professional. And it's malpractice. The most common type of negligence in practical nursing relates to the action or the lack of an action. Either, we gave that medicine, without checking that pulse, or, we did check the pulse, but then, we didn't do whatever we didn't come back and reassess that client in 2 hours, at a minimum of every 2 hours. Oh yeah, we noticed that client, they were a little drowsy this morning. I just thought they stayed up that night. We didn't do a focused assessment to see, why was this client drowsy? Did we ask questions? Do that focus assessment? Did we do the, orientation check? Did we do reality check? Did we ask that, do a more focused assessment? Okay, so now we're changing gears here. Battery and assault. Okay, let's put them on the board here. Battery, to cause physical harm to someone. Performing a procedure without a patient's consent. Remember, we just said the patient had the right to refuse. If they do not want that bath, if they do not want that finger stick done, that patient can refuse it. We document it, we report it. We make sure the client makes an informed decision. Tell them why it's needed, all of that. If they still say no, we leave them alone. We document it and report it. In the event that we go ahead and just do that procedure without that patient's consent, that means we have caused harm to that client. So what about if we threaten the client in room 201? They just been ringing that call like, look at this medication. Let's see what I can give them to put them to sleep. That client might have a sleep aid order, but that client, that's not what the issue is. The issue is the nurse is tired of the client ringing the call light or whatever it is. So we're threatening to give that patient that medication, not while it was actually ordered. So that's an unjustified attempt or threat to touch someone. Okay. All states have mandatory reporting laws for abuse. We are mandated reporters. Nurses are obligated to report suspicion. We don't have to know all the facts or confirm or know everything, but if there's a suspicion, we must report it. This is another slide on sentinel events are defined by risk or occurrence or serious harm and must trigger immediate institutional investigation. It's defined as an unexpected occurrence involving a death or serious physical or psychological injury. Like the examples that I gave, person goes in for surgery, get right hip replaced. And these are things that have happened, you all. I don't know what has happened. They went in to get the right hip and it ended up with the left hip done. It's like, what happened? What happened? So you all tell me, what is a chemical restraint? So someone come off mute. Let me hear from you. You all have been really active tonight. We haven't used our chat yet. What's a chemical restraint?
Like what you said, when you give someone a medication to put them asleep just because they're doing something you don't want them to do.
Okay. What about physical restraint?
Like a strap, a bed strap. There we go. My brain's not working. Like leg straps or arm straps or wrist straps, if they're just like misbehaving in the bed or.
Great. Yes. Then they have all different kind of restraints out there. That's physical. They have some just for the arms, the wrists, this. They even back in the day, they had these chairs, wow, and they were like, what's the little chairs little babies walk? You're trying to teach, they're learning to walk and they're getting busy. We put them in those little those little chairs and they can move around. It has the rollers up under them. What do we call those things, y'all? The I don't know, but you all know what I'm talking about, right?
A walker?
The walker. I couldn't think about it. So
No.
there was a thing. We didn't call them walkers back in the day, but it was just like that. What do you think was wrong? Why was that considered now a physical restraint? Think about that walker.
Because they were confined.
They were confined. They could not easily get out of that. Once you put that baby in that thing, and the walkers for the adults were not like you pick the person up and put them inside. But once you place them in there or they sat in there, you click when you clinked when you did the lock, they could not undo the lock. If they cannot undo the lock, it's considered a restraint. So I haven't seen those things in years, but it was good. But they could not, in the definition of a restraint, it wasn't good. Now, did it allow the people to move around like they wanted to? There were less falls. Yes, it was, but the person could not get out of the device. I forget what we called them. So it was considered restraint. So I haven't seen those in years, but that was such a thing. Administering medications, like the example that we just gave. So they're all kind of physical restraints. You kind of don't see them much in facilities, just depending on the setting. They kind of tend to not to use them. There is even one facility, they're not even using side rails. Because again, if you think of the definition of a restraint, can a person really let those side rails down if they're in that bed? Not
No.
really. Now, hospitals, for the most part, how we get away with it is we don't have all of them up. We have like the four rails, and one part is down, either one side is up. But in a long-term care facility, some of them they don't even have side rails, you all. Literally, do people fall out of the bed? Yes. And so we question it, and they said that they had this huge document, of course, evidence-based, the information that had been reported with a number of broken arms, broken necks, all of these injuries that were directly related to a side rail being let up and down. Wow. And so that led to, now some facilities still have it, but anyways, that led to the discussion about not having side rails. They said that the benefit of not having the side rails was more than it outweighs the risk. Now, like I said, they do still have people that fall out of the bed, but someone getting their neck broke or arm broke because we're letting up a rail up and down and we're not paying attention. They didn't want that. They rather had a person fall out of the bed. And then they also said, well, hey, at home, unless you have that hospital bed, you don't have side rails. But still, we're talking about people that can't maintain upright posture, will need assistance with turn every position. And what did they say? There are plenty of devices out there that you can use that's not a side rail that can also assist with people turning in reposition. So you see, like, and I don't know what we call them right now. To me, like huge beanie babies. They have like all this little stuff inside of them. You see all different kind of things that people have designed. Well, they're likely they're nurses, so you all may be thinking of something that you can patent, and we'll put it into use, and we'll be buying your product. But that was a huge discussion. But the literature, you all, it was like, wow, that many people sustain injuries from letting bed rails up and down. And it led to some facilities just pulling their rails. So we have libel and slander. Defamation, damage to one's character can be through slander. What are we saying? And libel through written. So some examples is sending an email to the editor of a newspaper and posting on social media. You ought to be careful what you're sharing. Because if you're sharing it, it's just like you're saying it. That's what they say. So, you might want to just look at the thing, whatever it is, and just keep on moving. But be careful with posting and things like that. So false accusations on performance evaluations. That's another example. We talked about HIPAA. We want to keep the client's information private. We talked about the National League of LPNs. In all healthcare professionals, that's one of their pillars. Keeping the client's information is expected to keep it private. No matter how many times that family member's coming to you asking, we can encourage the patient to talk to their family members about whatever it is. We can encourage, but it does not mean that patient will talk to their family members. But it's still on us to keep the information private. And an additional task that you may have in a healthcare facility, you might be their privacy officer. Those are just some additional tasks. Ethics committee. So when you all go to do your onboarding for whatever setting that you all decide, you have your main task, but the ethics committee, that's an additional committee that you can work on. So you want to ask too, what other things can, I do and assist within this facility? You might even be the public relations committee. You be the face of that organization. So if there are health fairs and different things around town, someone from that committee will go and represent that organization. So privacy officer, ethics committee personnel, and public relations are three that come to mind. But keep people's private information private. Patients can have a copy of their medical records. It belongs to them. Now, some facilities, If they have it printed out, they'll charge so much. Some facilities don't. They have to sign off on it and all that good stuff. But it's, their information. The nurses, we must adhere to the minimum necessary rule to protect that patient's privacy. So an example would be if we have a patient that is needing some type of medical supplies, they're getting, a wheelchair, walker, crutch, some type of medical supply. And that representative from that company calls and say, hey, we need to know some information about this patient we're getting ready to provide this for. They only need the client's name, their address, because they're delivering this medication or medical supply to them. You need to know where it's going and then how they're going to get paid for it. They don't need to know admitting diagnosis, discharge diagnosis, their whole list. They don't need to know all of that information because it's not necessary. Remember, we want to adhere to the minimum necessary rule. So only the information that is really needed for that client to receive those services is what we give out. We talked about this, the client's right to consent. The client's right to consent or refuse treatment is supporting that client in their autonomy. They have the right to choose. Performing procedures without a patient's consent, that is not good. We don't want to do that. The client can change their mind in the spot on the spot. Like the example that I gave, going to the OR, we're in the elevator. Whew, I don't want to do it. Okay, let's get off. Let's notify your healthcare provider. So informed consent, this is what it all encompasses. If the clients want questions clarified, we need to clarify that before they sign that dotted line. If they want to know the names and qualifications of people who will perform the procedure, we have to let them know what that is. If they want to know about alternative treatments and the benefits and the possible side effects, we need to let them know. Informed consent does require, at a minimum, all of this information client specifically wants to know. Explanation that the client has the right to revoke, change their mind whenever they want to, even after they have signed, at any time. So telling a patient that they cannot leave the hospital is an example of imprisonment. Remember, they can leave against medical advice. We just need to let them know, hey, all the information so they can make an informed decision. You can't hold them there. So living will, a legal document that describes the kind of medical treatments or life-sustaining treatments the person would, what they want, or what they don't want. The dual medical power of attorney, it has a proxy. It specifies a person. The living will does not specify a person. So that slide that we were talking about where, we're obligated to let the family members know is because if they are listed as that different medical power of attorney, and it's usually like one person or maybe two. So these are legal documents that DNR in the event that it says, this person's a DNR and we go in and find them without heartbeat, all those things. We cannot just start CPR because we want to. That's a legal document and we have to abide by that. Advance directive based on the Patient Self-Determination Act, it gives a physician the legal permission to write such an order. And I'll stop and see if we have any questions in the chat. The clients have a right to that. Make that decision. They do. I'm gonna pause here and see if we have any questions. Do we have any questions? All right. So that was just me putting all those slides together and mixing them up and being repetitive and mind you, that's how we actually remember things. Even if we're not trying to remember stuff, if we hear things so many times, it's like it becomes part of what we know. All right, so now let's go back. Let's toggle back. We have, in a nutshell, covered everything, but I want to go back to getting it pulled up here. Go back to our modules. Let's look at our points to ponder. We put in some look at that. We have an announcement section. I don't know if you are going to be able to hear this or not, but I'm going to try it. Okay, it's loading. Hold on. There's nothing to see or hear just yet. Hold on. It's loading. I might have to try it at the end. Okay, it's still trying to load. Let me go on to the next thing while it's still loading here. Nothing to see just yet. I'm still trying to pull it up. So what did we say in the chat, you all? We want everybody to respond in the chat. Paraphrase what moral distress is. We talked about it. What is moral distress? That video still not pulling up there. So in the chat, and just send your message out to everyone so everyone can see. What is moral distress? Open. Okay, let me share. So send your responses out so everyone can see. Okay, about 30 more seconds. Moral distress. You're defining, put it into your own words, what it means. And you're sending it out to everyone. Let me see what we are saying here. Okay, let's see. Okay, good. Make sure you respond. Make sure you respond. And then the next thing, once you have responded, look and see that we match. You doesn't have to say specifically. You're paraphrasing. Just do a self-check. Does your response match what the slide is saying? Okay. And so what we did was just another, even though we use more distress as that's still another test taking tip. Remember that you know what you know. You have that foundational knowledge. And so as you're reading the scenario and you realize that the question is about whatever the concept is, and you're reading the answer choice, don't try to change what you know to match what these answer choices are there. You know what you know. Even though you might not use the exact that every word on that slide, but you still, your paraphrase statement still it meant the same thing as what was there. Good, 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 good. Okay. All right. So just a few more minutes and we'll go to our next break here. Let's look at let's dig deeper. Let's look at our slides here. All right, let me share my screen. Yeah, remember that little what was the cartoon? Baby Shark? I don't know where that something just pop up in your head. Like, wait a minute, where'd that come from? All right, so in the chat, I'm just gonna give you, let's do 2 minutes. So this is another test taking thing. You know, you're timed on those exams. So read through this and in the chat, put ABC, A, B, or C, whatever your answer is. Let me get my little timer pulled up here. 2 minutes should be enough to read through this, go through your information, and in the chat, drop just A, B, or C. All right. I'm going to be on mute, so I won't interrupt your thoughts. Okay, let's see how you did. Okay, so someone that got this correct, talk us through it.
I think
This
not
is
telling the patient their diagnosis or prognosis does a couple things. It doesn't give them all the information they need to make informed decisions about treatment or their future. Um, it also could probably affect them emotionally if you don't tell them the information. You're trying to hide the information to maybe not hurt them or scare them, but they probably need that information to maybe um, process it and then be able to tell family members so that they can get um, help or the appropriate treatment that they may need.
it's do no harm. That's what it is, basically. What she's saying. Do no
That
harm.
is that. So that's exactly that is. She walked us through a scenario, and then you summed it up. Do no harm. So this is so veracity. We still got to tell the client, be truthful with them. But then you have this, hey, if we tell them this, is it going to cause some harm to this client? Psychological distress. So then you wrestle with that, and then that's an example of veracity, telling the truth or letting them know, and then maybe causing this client some psychological distress because we're telling them, making them informed about what's going on with them. So for this one, you had to know all of these definitions. It is still the same thing. You identify the concept. So the first one, it says veracity. So you knew what that one was, and then it says versus. So next gen, you all, they're gonna rarely ask you a definition of something. You're gonna have to know what it is and be able to apply it to this situation. So the example that she just gave, and we summed it up, doing no harm. That was great, great, great. So we need to stop. We need to pause. The other thing we can do, we haven't taken that last 15-minute break, but you all may need to stop and do the 5-minute break. Do we stop and take the 5-minute break, or push the 5 to the end, which will mean we'll have a 20-minute break at the end? What do we need to do? Because we do have, we can go for a 5 minute.
Let's push to the end.
We'll push them 5 minutes on back.
Okay. Am I hearing anyone that opposes that? Now, mind you, you can stop and go to the restroom and move around if you need to. Just make sure that you come back. So I'm hearing no opposers. Let me write this down on my paper here. So that means we're gonna do our lab 15 plus this 5, so that means we do 20 at the end. So we're supposed to end at 9:40, at 10:41. So that means we'll end at 9:21. So we're almost there, you all, because we're pushing it to the end. All right. We're not getting out early, is your time anyway. You're just moving it around. All right. So sources of the law. We said constitutional. We talked about this. We talked about those torts. Criminal. We want to make sure you all were just taking the time to do what we need to do. Medication administration rights, all those things. It is essential because the very time that we don't follow that, something's gonna happen. It's gonna happen, and it's just gonna come back. All these different types of healthcare law, but nevertheless, it goes back to what our scope of practice is. So if something comes up, if we're in our scope, even if a patient has a bad outcome, it does not mean all the time that the healthcare providers, the nurse, the doctor, the physical therapist did not do what they're supposed to. It doesn't mean that. But these laws, the scope of practice, the organizational rules and policies, procedures, they're there to protect us. So making sure that we're following that. In the event that that facility, that's something's wrong with their system, their way of doing things in that facility, when we said we need to report that to the healthcare, to the organization's chain of command. Hey, I know we're doing this example that I gave about the urgent care. I experienced that. I was in the urgent care and I was pushing them buttons. I'm not the best tech savvy, while I was like, now what somebody, I know somebody see me out here struggling with this. And it was, I don't know really what it was, but whatever, I was supposed to get a phone call or a text message. And then whatever I got, I was supposed to put it in the machine. I was not getting it. So I don't know if I didn't put the right, I don't know, but it was just like, okay, something wrong with this system because I'm in here because something's wrong. I don't have time to fool with this machine. I know they're trying to include AI and all this stuff, but sometimes there's a gray area. Those things doesn't work. And it could be, and just because you have the electronic medical record, and it's flashing. Another thing, I don't know if you have seen the electronic medical records. They flash white, yellow, pink, or red. I know we kind of rely on those colors, but your time frame for administering medications to be within the right, usually an hour before and an hour after. So I know we look at those colors and say, oh, okay, this thing is going to turn yellow when it's almost time for me to be out of my medication past time frame. But we still need to remember what that foundation is for us to administer those meds so that we are administering medications correctly. Anti-kickback statute, a criminal statute that prohibits the exchange or an offer to exchange anything of value to induce referrals to federal or state health programs. Another thing I want to do too, I'm gonna stop here just a few more minutes. We're almost done with this one. Is for you all to get into your groups. You all can just talk and introduce yourselves, and then move forward from there. Over the past several decades, I say that out loud to make me adjust myself because I do want to give y'all at least 10 minutes to do that. Over the past several decades, a staggering number of healthcare providers have been indicted or convicted or have been excluded from providing healthcare services under Medicare or the state's Medicaid programs for engaging in behaviors that solicit or pay for referrals of Medicare patients or beneficiaries. They're just saying that, they're writing down stuff or pushing stuff through or billing for things that are not supposed to be pushed through. Did happen or some type of issue. Okay. So once we read through this scenario, we do have a few questions and this will end our information here. All right. So we're going to give you a few minutes to read through this and then we'll move through the questions. So about 3 minutes to read through this. Set my little timer and get ready to answer. 3 minutes. All right, let's move forward. I didn't give you your whole 3 minutes. Got a minute left, but I think we're good on reading it. All right. So, what factors are contributing to Sheila's moral distress? And you can come off mute and tell me one at a time.
She doesn't want to hurt her work relationship with the doctor.
Okay. Anyone else? Okay. What if the issue is not addressed? What are some potential things or consequences that might happen if it's not addressed? Because what's happening in the scenario? Someone give us a synopsis, a short of what's going on in the scenario.
He's committing fraud pretty much because he's charging for stuff that's not needed.
Okay. All right. And so going back to the question, what are some things that could happen, potential consequences if patient care issue, if this issue that's going on is not addressed? What could potentially happen?
You could lose a patient's trust
Okay. What does that have to do with anything?
because they're like trusting you, providing them the best care, and you're ordering them tests that they don't even need because the doctor's spouse gets a bonus.
So what does that, the
Your
next
insurance,
step? Go ahead.
and they're being charged for this. They're being charged for something they don't necessarily need.
Mm-hmm. So what could that lead to for that nurse, that facility,
It
that
can be shut
community?
down.
Exactly. That's what I was just saying. What does that have to do with anything? But yes, I want you to take it a step further. Yes, all that is true. What you all just said. It could be shut down. It could be the nurse, the doctor, that facility being reported to the whatever those powers that be. It could be jail time. Remember we looked at that criminal jail time. It could be considered as a felony. It could be fines. It can just get really, really ugly if it's not addressed. Even though you love Dr. So and so and all of this, but if we're finding out that they are doing things, just even if the colleague reporting, we were saying that our colleague, we saw them putting the medication in their pocket, taking the medication. They pulled it out the drawer and put it in their mouth. We have to report that. Okay, so then the next
Would
question.
that consider financial abuse?
Exactly. That's the category that it falls upon. Mm-hmm. What should Sheila do in this situation? Are there any support systems that can help the nurse in this setting?
Whistleblow.
Got it.
Okay.
Yeah.
Document what she sees.
Okay. Document, report it, whistleblower. Exactly. All right. I'm trying to find a little paper here. Trying to open. Great. All right, I'm going to pause here. Are there any questions? What I'm getting ready to do is transition. I'm going to try to put you all in your groups real quick. Just give me a moment. I don't see any questions in the chat. So just give me a brief moment to put you in the breakout rooms. Give me just a moment. Okay, thank you. Okay, thank you for letting me know that I'm sure it's something with the connectivity. Here we go. Let me put you in the Miss Gary, you realize you're on here twice. I don't know if you have both your devices open or not.
Yeah, no, I'm on here twice, so I didn't want to log off from the other one because my camera.
Okay, yes, you did tell me that. Okay. Almost there, you all. I'm clicking as fast as I can go. Mm. Okay, I'm getting ready to open up the breakout rooms. So accept the invitation to go there, and you're gonna just greet each other and exchange and just talk about how you want to communicate here going forward, email, text message, whatever you all decide. And then I'm gonna post the sheet that says your topic that you're gonna do your PowerPoint on. Post that while you're in there, just chit chatting for a moment. So just go on and do your greetings. I'm opening up the rooms, accept the invitation. Alexandria, Miss Hunt is having trouble getting back in, so you can just stay here with me. And so everybody else go over to the breakout room, introduce yourselves, and we'll bring you back here in just about 4 minutes.
So don't join.
No one, yeah, your group member isn't in the room. They're having connectivity issues. They've been logging back and forth. They've been getting dropped off and on. So you just stay right here with me for just a moment. She may log back in. She has been logging back in. Everyone else should accept the invitation to the breakout room. So you're just introducing yourselves, talk about how you want to communicate going forward. And then I am going to post your topic and your groups as a whole in the announcement section. So Ms. Gore, I place both of your devices over. So the breakout rooms are open. You all accept the invitation. Okay, Ms. Nichols, you're still here. Okay, she just went over. Ms. Gore, I think you didn't take both of your devices. Are you still there, Ms. Gore? Ms. Alexander, do you see the invitation? Sarethia. Lee and Alexander, you all are supposed to go to the breakout room.
I don't know why, but mine is not like I went and then
I went and nobody's in there.
nothing.
So
That's
just
what
stay there until they get there. So they're coming. They're coming. Maybe connectivity issues.
Okay, is it me and just somebody else? Like how many people is in there?
Yeah,
can I
it's you
reconnect
and another
them?
person.
Okay, are you able to reconnect me back in there?
Me too.
Who's that talking? Who said me too?
It's Aisha. For some reason, I went to the one that was on my phone. I connected it, but I didn't do the one on my laptop. And so when I went back and canceled, it disconnected me off my phone. So now I got to log back in on my phone because, like I said, the camera went out. I don't know why, but the camera kept saying Wi-Fi bad. I don't know.
Yes, it's that connectivity issue. Okay. So just hold on. I'm seeing I'll put you in. Who that's Miss Lee talking? Your other person fell off. They had connectivity issues. So just stay right here.
Okay.
How many people is in each group?
Are we in the same one, Alex?
Don't give me the line, baby. I don't know.
Huh?
I said, don't give me the line. I don't know.
What are we
I
supposed
know me
what are we supposed
is
to be doing?
going to the breakout room. You're on mute, Dr. Ford.
I think this should right here just be a whole group right here, Dr. Ford. This might be your group because I don't know what's going on.
It's just a connectivity thing. So we bring everybody back. And that's another reason why we don't do it in class. You have to meet outside of because you just never
I have
know. My
I have a
connectivity
question.
might work and yours might not work. So it has to, it's enough time, not enough time during class to do
Is
it.
it? I have a question. Is it too late for the ones who are some of the ones are on here? Can we request a member like because if we're like already at a campus with the person to be their partner, are we allowed?
You're in groups by campus. Yes, you're
Okay.
already there. Mhm. All right. So I think we have everybody back. So for your group 10 project, let me pull it up. You cannot rely on classroom time to complete it. There is not enough time. There
Oh,
are connectivity issues. This was just to say hi, just on a smaller scale, just speak and talk to each other. There's just not enough time. It's not due until week 10, you all. But that does not mean that we want to wait until week 9 to get it together. So I'm scrolling down to week 10. It is a PowerPoint. So it is going to require, I'm pulling it up. You got 2 minutes here. It's going to require you all meeting, deciding however you all want to meet. Um, let's see, here we go. And so in the announcement section, you will see your group member's name. You all decide if you want to meet via text, email, on campus, however you all want to do it. You don't even have to meet on campus. However you all want to do it. Decide on, you have a topic. Your topic is there. Look at the rubric. And so this is, you're going to break these, for example, PN and the nursing process more than TATS. You're going to piece all this. You're going to have a slide. There's not a slide count. Is this one have a slide count? 10, a minimum. This one doesn't have a slide count. It's a time count. So no matter however many slides you all decide upon, make sure you talk about your topic thoroughly. Make because you have to talk for a minimum of 5 minutes. Your presentation, it is a PowerPoint. You be as creative as you like, but make sure that you're covering whatever falls up under your topic. I'm getting ready to post in the announcement section the groups and your topic. So you can click there and you can find out what your topic is and who you're working with. And so you only work on your topic. If you have PNs and shared governance, having a voice in healthcare, that's all you look at. You all decide what you want to include in that, but just make sure you refer back to your rubric. It is a PowerPoint. If you and I are working together and you say we decide I'll do 2 slides, you do 5, that's fine. That's what the group has decided. But we are going to turn in the 7 slides that we have completed together. Both of us, if there's 2 of us in the group, we both return that same product. And so, all right. So it's the end. You're going on break. You do not log back in. We pushed our other 5 minutes with this 15 minutes. At a minimum, look back at your classroom recordings for your content. The exam review recordings, if you can't attend them, they will be shared. So at a minimum, look through your classroom recordings. I'll stay up and download this and upload it tonight so you can get a heads up on it. So you can chunk it up and look at it. All right. Take care and we'll see you on next week.
I have a few questions about the project, if I could ask.
Sure.